Hello, everyone. Welcome to another edition of Cracking the IR Code with Stacie. I am Stacie Buck, President and Senior Consultant of RadRx based in Stuart, Florida. So here we are with case study number 2, and this week's is going to be a little bit less complex than what we looked at for the first one. I've chosen to look at a case with a lower extremity arteriogram, also with an angioplasty performed with stent placement. So first, let's take a look at the clinical indication that is going to be treated. So we see here that the patient is a 72-year-old male with a known left popliteal aneurysm. So we have 2 key pieces of information here. We see that the aneurysm diagnosis is known. So that is going to be a piece of the puzzle in determining whether or not we're going to assign diagnostic angiography codes. And then also the clinical indication is important to know because that determines what therapeutic intervention code we are going to assign for this extremity angioplasty and stent placement. While most cases in the lower extremities are coded with 37220 through 37235 code range, those codes are used for occlusive disease. And whenever a patient is being treated for non-occlusive disease in the lower extremities, then we're going to look at different codes. So let's just do a brief review of the procedural steps. Whenever the physician has numbered procedural steps at the beginning of the report, I like to read through them, and I usually make notes of what the codes would be for each one of the procedural steps. Now, you can't code your final codes from the procedural steps, but it gives you a good clue as to what you should be looking for in the report, and then you will look for supporting documentation for each of the procedural steps that are listed. So first, the physician had ultrasound-guided percutaneous access of the left common femoral artery. So we know we're going to have some documentation to look for there to report code 76937. Also, we see that superficial femoral artery being catheterized with arteriogram. And then there's a stent graft placement into the popliteal artery. We have some follow-up angioplasty, and then we have a post-stent left lower extremity arteriogram. So we see that for this case, the anesthesia says that conscious sedation was used, both Versed and fentanyl. So we don't have the detail in this report to be able to pick up those codes, but it does say see separate report. So sometimes the detail on conscious sedation will be provided in another portion of the medical record. Personally, myself, I recommend for a best practice that the complete statement about conscious sedation is included in the report, including that the supervision occurred by the physician performing the procedure, also documenting the amount and type of drugs that were administered, and then also, of course, the total number of minutes of sedation time as well. So let's jump into the technique. So again, just as I will always do, I will highlight the pertinent points of the documentation so we don't have to read through every single word in the radiology report. So this procedure started with ultrasound guidance. It says under ultrasound guidance, a micropuncture needle was advanced percutaneously into the left common femoral artery, antegrade, and the guide wire was passed into the profunda femoral artery. So right now we have mention of that ultrasound guidance, but we do not have any documentation that is required for ultrasound guidance. Remember, the code description itself is going to tell you what's required. You have to have documentation of vessel patency. There has to be documentation of real-time vascular access. There also needs to be a permanent image stored. So we don't have enough documentation to support the 76937. At this point, the physician had only catheterized the left common femoral artery. That was the point of access. So we start out with a 36140 for the catheterization code. However, the physician is not going to keep the catheter there. The physician is actually going to move the catheter. So after the statement, the physician is mentioning positioning of the guide wire. Now, you're not going to code your catheterization codes based on positioning of the guide wire. You're going to code them based on positioning of the actual catheter. So you always want to make the distinguishment between the guide wire and the catheter placement whenever you're coding your reports. So in the second paragraph under technique, it says over this, the catheter was then exchanged for a KMP catheter. And so here you'll see that I have 36245 that is actually crossed out there. If we look up at the statement above where it says this was used to redirect the guide wire into the superficial femoral artery, first the wire went into the superficial femoral, but then over that, the catheter was then exchanged, and then the catheter was advanced. So we know that the catheter went into that superficial femoral artery. And then at that point, that would have been a first order catheterization of 36245. This is a procedure where the physician is actually going down the extremity and not going up towards the aortic bifurcation. So this is why we have a selective catheterization at that point. So that superficial femoral is a first order off of the left common femoral. And then notice that's crossed out because the physician is going to continue to move the catheter. From that catheter placement, the physician mentions an injection of contrast for a lower extremity digital runoff arteriogram. Following that, note that I made the comment that it's non-diagnostic. In the indication on the report, the patient has a known left popliteal aneurysm. So to report diagnostic angiography, it would have to meet specific criteria. First, there would have to be no prior catheter-based study performed when we're talking about CPT guidelines. And then the decision to intervene would have to be based on the study. Even if there had been a prior study, there has to be medical necessity. So in this case, there's no indication that this was like diagnostic. If there's any doubt, then you could always go back and query the radiologist and ask them whether or not this was a diagnostic angiogram. As a word of caution, I will tell you that many times radiologists will call all angiograms in the report diagnostic angiograms, but for coding purposes, they actually are not. So you should go back and review the criteria in CPT on that to report a diagnostic angiogram. And the main key when you're reading those guidelines in CPT is whether or not the decision to intervene is based on the imaging. So absent a specific statement about that, you really cannot make the determination. The best we can do is look at the indication and consider that the diagnosis was known. So the way the report stands currently, I would not recommend picking up the diagnostic angiogram. So let's jump down to the third paragraph where it says, over the wire, a Viavon stent graft was passed and deployed across the popliteal aneurysm. So now the catheter has moved from that SFA into the popliteal. So we've gone from a first order down into a second order, which is 36246. So that's why that 36245 was crossed out, because the catheter was placed into the popliteal to put the stent in place. It goes on to say that it was extended superiorly using another Viavon stent that's overlapping the first. So here there are 2 points to pay attention to. So first, notice that the stent code that I've chosen is 37236, and it is not a 37226. The reason being that the patient is being treated for a popliteal aneurysm. This is non-occlusive disease. Whenever the patient is treated for non-occlusive disease, then you will look to codes 37236, 37237 when we're talking about arterial procedures. If this had been a situation where occlusive disease was being treated, say a stenosis, then that code would be 37226, but that is not what occurred. Also, the difference in coding that occurs on a 37236 versus a 37226 is that with a 37236, we will report the catheterization code separately. However, if this had been a 37226, then the catheter work would be bundled. So always paying attention to that clinical indication is going to be key. So that's number one. Number two, 2 stents were placed, but they're overlapping. So only a single lesion, a single area is being treated. So based on that, only 1 stent code is assigned. In order to use the stent add-on code for a second stent or other additional stents, then you would actually need to see that separate lesions and separate vessels are being treated in order to pick up the add-on codes. So after the overlapping stent was placed, then from there, the physician did an angioplasty following stent placement. When angioplasty is performed in the same vessel as stent placement, that is going to be bundled. So there's no additional coding there. And then we also see the physician wrap up with a lower extremity arteriogram post-procedure to check the results of the procedure. So we can see the final codes for the case based on all of that guidance. So to the conclusion, we can go read through that. And then because we're not coding for diagnostic angiography, you don't need to dig into the details of the conclusion. If we were coding diagnostic angiography, if the report supported that, then you would want to dig into the details and then make sure that you actually have all of the detail required to assign the imaging. So that brings us to the end of the case. So our final CPT codes for this case are 36246 for catheterization of the popliteal artery, and then 37236 for stent placement of the aneurysm. All of the other coding that took place or all the other work that took place in this case is going to be bundled. So I hope you enjoyed this second case study, and I look forward to connecting with you again very soon. Thank you.